This work was actually published back in April in Circulation Quality, Cardiovascular Quality and Outcomes, and was a collaborative effort involving multiple interventional cardiologists across the state of Michigan, led by Dr. Gurm at U of M. And so if you want to follow up any findings or figures that you see in the presentation today, you can find them there. So as you all are well aware, PCI is one of the most common cardiovascular procedures that we do, and over the last several decades has improved significantly, not only due to advances in PCI devices and pharmacotherapies, but because we have really strong quality improvement initiatives. These include things like self-reported registry data, pay for performance, quality collaboratives. Um, but despite all of these efforts, there still remains variation in safety and quality across sites across the country. And so the goal of our study was to use our unique BMC2 cross-institutional peer review system, which kind of uses the idea of shared learning to look at PCI quality and safety. We then looked at the appropriateness ratings for PCI between our peer review process and registry-based scores, and again looked at variation across BMC2 sites. And our hypothesis, again, was that while quality in PCI overall has improved dramatically over the last several years, there still remains some variation. You can go to the next slide. So this is a central illustration from our paper, which goes through the peer review process, which I think you all are probably much more familiar with. But just to kind of quickly summarize, we selected single vessel coronary disease PCI cases from the BMC2 registry to be reviewed by peers. As you all know, data from the case is then uploaded. So this includes H&Ps, angiograms, stress testing, procedure reports. This data is then given to operators who are both internal and external to the institution, which is one of the unique aspects of this peer review program, is that we're getting feedback from folks external to the institution. The physicians then review cases and complete a peer review form, which I'll show you in a moment here. And then hospitals get that feedback at the operator level and can do with that what they want to kind of implement change. I'll dive into the results in a bit here, but as you can briefly see, generally what we found is that PCI is both appropriate and of high quality in Michigan, which is great. Complication rate generally low in the 11% of case range. But interestingly, peer reviewers were a little more stringent with their appropriateness ratings compared to registry-based appropriate use criteria. You can go to the next slide. Again, I'm not sure how frequently you see the peer review form, but this is just a snippet of what the physicians fill out. There are a series of multiple choice and Likert style questions asking about the appropriateness of the angiogram, the appropriateness of the PCI, quality of the angiogram, quality of PCI, and then a series of questions on whether any complications occurred and how those were treated. And so all of this data we have access to for this study. You can go ahead to the next slide. So in our analysis, we included 961 cases. Again, these were just for single vessel coronary disease. About 65% of cases were reviewed by at least 2 reviewers. And so this resulted in over 1,600 total peer reviews, which is really impressive. For this particular analysis, we focused on reviews that were performed by operators who were external to the institution to really focus on the outside perspective on how the case was performed and the practice. You can go to the next slide. Diving into our findings, what we found is that, again, generally PCI is of high quality in the state of Michigan. When operators were asked to rate the quality of the angiogram, 96% of cases were rated as excellent or adequate. Operators were asked to comment on whether there was a complication and or a suboptimal result, and this was only identified in 11% of cases. Interestingly, of those, 44% were considered avoidable, which highlights probably the opportunity for peer review to make a difference here with that feedback. The common causes for suboptimal result, the most common was inadequate lesion prep in over 40% of cases, followed then by stent length and sizing, which is again is helpful feedback to get for operators. The good news is reviewers felt that in 70% of those complications, they were recognized and treated appropriately. So overall, this is good news for PCI quality in the state. You can go to the next slide. Then we looked at the appropriateness of the PCI. So was this an intervention that we should be performing? And overall, 87% of cases were rated as appropriate or may be appropriate. I think what's important to highlight is that this varied by indication for PCI, which is probably not too surprising. So PCIs that were performed for acute coronary syndrome, so STEMI or NSTEMI, were considered appropriate since that's generally the standard of care. But there was a little less agreement in terms of PCIs that were performed for non-ACS reasons. Again, highlighting maybe some specific areas for improvement where we can drill down deeper with peer review. Next slide. Next, we compared the appropriateness ratings that were given by our physicians to registry-based appropriateness classifications using appropriate use criteria. And I think this is really interesting. You can see on the far left that operators considered 73% of cases to be appropriate, whereas AUC criteria would classify 93% of cases as appropriate. And similarly, operators within BMC2 were more likely to rate a case as rarely appropriate than the AUC criteria. So again, it appears our operators were a little more strict with their appropriateness ratings, and we can certainly theorize why that might be the case. It's possible. I mean, some of this could be just due to intra-rater variation. However, it's also possible that with the level of clinical detail and they get about the case, they can make a more nuanced assessment of the appropriateness. They have access to the actual angiogram, to the HMP, and so that may allow them to better evaluate these cases. And is really a strength beyond what typical registry-based appropriateness can provide. Next slide. And then lastly, we saw that while quality and appropriateness are high in general, there is variation across BMC2 sites. In the top left-hand corner, these are the percentage of reviews that were classified as rarely appropriate, so like probably shouldn't have been done. And across the Y, the horizontal axis, these are different hospital sites. And so the percentage of cases rated as rarely appropriate ranged from 0 to 18%. On the bottom left-hand corner, we see the percentage of reviews that were classified as not technically competent or like really the procedure should be reviewed. And this also varied across hospital sites. And then on the far right, we looked at the percentage of reviews or cases that were classified as both appropriate and of high quality. And this ranged from 76% of cases to 100% of cases. So again, generally high quality, but there is some variation across our BMC2 sites. Next slide. So we really feel like the peer review program adds a lot of value for a few reasons. One, again, it provides more nuanced feedback that you can't capture with just registry-based classifications. And this is not only in the form of the quantitative feedback in terms of the scoring of appropriateness and scoring of quality. But what I didn't highlight here is that operators also get really rich qualitative feedback as well. In our paper, in the supplement, there's a table that kind of summarizes the open-ended feedback and comments that operators got. So there's a section just for open-ended comments, and we found that there was really valuable feedback in that area. Around the themes of medical decision-making, operator technique, management of complications. And so, again, this is really impactful in terms of changing practice, and really can't be captured by just registries alone, and requires this sort of peer review system. I think another really valuable aspect of this peer review process is that it encourages collaborative learning and kind of reflective practice, not just within institutions, but across institutions. So again, I think one of the strengths is that you're getting feedback from an operator outside of your institution, because we often see that practice patterns within an institution can merge, and people may practice similarly. So hearing from someone outside of your institution can be really valuable feedback as well. And then lastly, peer review really just allows for professional self-regulation. Next slide. And so certainly this peer review process is not without some of its challenges, and you all are probably much more aware and involved in those than I am. But as you know, there are a lot of time and logistics involved in a cross-site review system. The manpower that goes into uploading all this data, getting the physicians to complete the reviews, can be cumbersome. And so again, adds a lot more work than just beyond what our registries can provide. I think there's also the question of how to integrate feedback into the hospital workflow and how to best use that feedback. I think one of the big things too is if we think about scaling this beyond Michigan, it can be really challenging. We are very fortunate to have the BMC2 infrastructure, where we share information with each other. But I think if we're looking outside the state of Michigan, where they may not have these statewide consortiums, it's a little more challenging without that infrastructure. But I think moving forward, our hope is that this would be more broadly adopted. We could also look at more complex and high-risk cases, so multi-vessel PCI. We have some peer reviews on cases that involved mechanical support or cardiogenic shock. And I think it's possible that when you include some of those higher acuity, higher risk cases, there's probably even more opportunity for peer review to be impactful, where practice isn't always as clear or standardized. And then finally, we really need to look at whether this peer review process has any impact on outcomes and cost at the end of the day. Next slide. So really, I hope you can see that we found PCI in Michigan is really overall high quality and very safe. And is a really promising way to do that. I think from our analysis, the non-ACS PCIs really offer the most opportunity for improvement, but thinking about including some higher acuity cases in the future. And again, blinded peer review is really a promising way to kind of complement our already existing registry-based efforts. So thank you again for having me. I'd be happy to take any questions that folks might have, and again would encourage you to kind of look at the paper there in the supplement as well. Like I said, there's even more data on kind of the results of the peer review process and the feedback that was given.